side. As you know, the natural history of tuberculosis, as you have seen on this slide, we have cases which were initially naturally uninfected individuals would develop what we call TB infection, and the next step. Yes.
Excuse me for interrupting you. Can you make your slide on slideshow mode?
Okay, let me make it. Yes. Now.
Yes.
Yeah. So now what we are focusing globally as I eliminate tuberculosis worldwide, we are trying to focus what we call incipient TB. What does it mean is individuals who have a TB infection, which was confirmed by being a risk, plus confirmed by biochemical profiles of TB infection like tuberculosis skin test, which is an immune reaction to tuberculosis, or IGRA, that is interferon gamma release assay. So those individuals who are highly susceptible to develop tuberculosis disease but not yet have any features of tuberculosis disease are called incipient TB. For example, we consider incipient TB individuals like tuberculosis infection plus retroviral infection, diabetic patients, socially disadvantaged congregations like prisoners, or patients who have a confirmed malignancy, and patients who are on immunosuppressive drugs for a long period of time, more than a month, are usually considered as incipient TB. Subclinical TB, that is the tricky part. Subclinical TB is it is an individual has an imaging or histopathologic features of tuberculosis plus a confirmed microbiological tests of tuberculosis, but no any symptoms and signs of active TB. The simplest that everybody can diagnose is probably, it's not always simple, as I said in words, is a tuberculosis disease, which is symptomatic patients with imaging plus or minus histopathologic features and the confirmed microbiological tests are called tuberculosis disease. What is the challenge nowadays is we don't give a focus on diagnosing of incipient tuberculosis. That means we have to rule out the possibility of active tuberculosis in individuals who are at high risk of reactivation tuberculosis, like retroviral, immunocompromised. Those individuals who are taking immunosuppressant drugs for more than a month's period of time should be screened for active tuberculosis. If they are negative, what we have to do is we have to confirm, not yet applied in our setup, but I think the ministry and WHO are on a pipeline to start what we call a TB antigen-based skin tests. TB-SCT is going to be started soon. So this is one of the things that we have to focus in diagnosing of tuberculosis, not only a disease and a subclinical disease, but also in diagnosing of tuberculosis infection, particularly incipient TB. That's one important point. Subclinical TB, usually diagnose it while you are screening for other issues. What I usually face is diagnosing of subclinical TB is those immigrants to the West or immigrants to Arab countries. They are usually screened for active tuberculosis. In the meantime, they found to have a subclinical TB. No symptoms, but imaging findings plus confirmed by bacteriological findings. Now, I'm going to say a few points on one important topic, what we call it, can we diagnose clinically pulmonary tuberculosis, what we call clinically diagnosed pulmonary tuberculosis, because so many topics has already been discussed by Dr. Abata. I don't like to repeat them, but I will go directly to clinically diagnosed pulmonary tuberculosis. This is the one for which a clinician has a big role in deciding of individuals who are microbiologically negative but decided to be treated by tuberculosis. So what shall we do? We have to do a repeated tests, bacteriological confirmatory tests like acid fast bacilli, gene experts, or probably culture if the setup is available, and if the clinician has a big suspicion of tuberculosis, we have to do these tests repeatedly. If they are negative, and if they have a suggestive chest X-ray finding or a suggestive histopathologic finding, now the clinician has a role to decide diagnosing of tuberculosis clinically. We call it clinically diagnosed pulmonary tuberculosis. What is a big challenge in clinically diagnosed pulmonary tuberculosis nowadays is if an individual has previously treated tuberculosis, we know that what we call it post-tuberculosis lung disease is a big challenge and a major differential diagnosis of clinically diagnosed pulmonary tuberculosis. So we need many experts. We have to consult each other. We have to think over it. We have to try antibiotics before we are embarking to anti-TB treatment while we are diagnosing individuals with clinically diagnosed pulmonary tuberculosis. We know that even worldwide it's accepted that you can diagnose clinically pulmonary tuberculosis. Even in Ethiopian context, we have 27% prevalence, which is the old data. And usually exclusion of other pulmonary problems is usually crucial. Nowadays, we use with most important imaging like high resolution CT scan, which can help to at least to have a supportive evidence in diagnosing of clinical pulmonary tuberculosis. Post-TB lung disease is a big challenge. I don't like to discuss all issues, but it is a very important differential diagnosis in the diagnosis of tuberculosis. I don't have time, that's why I'm rushing. So I will go to extrapulmonary tuberculosis. That's one of the most important challenges that we are facing now. As you know, in HIV negative individuals, what the epidemiological data tells us, 75% of individuals have pulmonary tuberculosis. The rest will have extrapulmonary tuberculosis. From this data, what we know is only 5% of them will have disseminated TB, and the rest of 15% will have extrapulmonary tuberculosis, among which tuberculosis lymphadenitis and pleural tuberculosis are another important points that we consider. In HIV positive individuals, disseminated TB is more common, followed by extrapulmonary tuberculosis, though pulmonary tuberculosis is not uncommon. So what is the challenges in extrapulmonary tuberculosis? One, it's not always simple to diagnose. That's what I want to focus. I'm not going to discuss each details. Already we may have another webinar in diagnosing of each forms of tuberculosis in each system, including genitourinary, abdominal tuberculosis, and musculoskeletal, CNS tuberculosis. We are going to discuss in details. But in general, diagnosing of extrapulmonary tuberculosis needs an experience. So unless we consult each other in diagnosing of extrapulmonary tuberculosis, we may end up, I think, probably in a wrong diagnosis or in over-treating of individuals. Second challenge in diagnosing of extrapulmonary tuberculosis is inaccessible sites. Usually in CNS tuberculosis, particularly in tuberculoma, or even at times in tuberculosis meningitis and tuberculosis spinal tuberculosis, it's not always simple to get a specimen, to analyze it, and to get a high yield. So inaccessible site is a challenge in diagnosis of extrapulmonary tuberculosis. Third point is majority of the tests in diagnosing extrapulmonary tuberculosis, except probably TB lymphadenitis and somehow pleural tuberculosis, the other sites needs an invasive procedure that to get a sample to analyze it and to diagnose it. Another very important challenge in extrapulmonary tuberculosis is there is no any specific sign and symptom that is usually incriminates only for tuberculosis. Tuberculosis shares the same symptoms and signs of other multisystemic diseases and even local diseases with others. So these are some of the difficulties or the challenges of extrapulmonary tuberculosis. I think I don't have time to consider each individual challenges of extrapulmonary tuberculosis. I'm sorry, I'm going to end up here. Probably if you are going to ask me questions, I'm going to go to the details. Thank you so much.